Hey guys, it's Matt from Mace. So let's talk about sepsis a little bit. Now, I'm not going to get into the pathophysiology of sepsis. If you want to learn about that, you can go to our website, check out, we got a whole hour-long CE video on sepsis where Dr. Axine will break down all that patho. But I just wanted to talk briefly about the recognition, how to recognize a patient may be septic, and then how to manage these patients. So let's take a look at two different criteria that can point us towards our sepsis patients. Okay, so this first criteria is the oldest criteria in relation to sepsis, and this is the SIRS criteria, or the Systemic Inflammatory Response Syndrome. This is basically what happens in our body in the presence of an infection. So we have an elevated heart rate over 90, we've got an elevated respiratory rate over 20, and then we have hypothermia, or a temperature, right? Now, a lot of medics get confused when their patient doesn't have a temperature and they say, well, my patient didn't have a temperature, how can they be septic? Well, there's lots of reasons why a patient may not have a fever. Maybe they just don't thermoregulate correctly, right? Especially older people, right? All their thermoregulation's been a little bit thrown off. Maybe they just took some ibuprofen or some Tylenol to help reduce their fever. The point is that your patient does not have to have a fever in order to be septic. That they just need to have a presumed or known source of infection in order to possibly be septic. And this last one is in relation to white blood cells. That's something that they're going to have to check in the hospital, unless you have the ability to do that pre-hospitally, but that's not something that we typically focus on pre-hospitally. So next, let's look at the Q-SOFA criteria. Okay, so here's the Q-SOFA criteria, or the Quick Sepsis Organ Failure Assessment. Now, the Q-SOFA is an abbreviated version of the actual SOFA criteria that they will use within an ICU, and that involves a lot of lab values and things of that nature, which again, we can't get pre-hospitally. So the Q-SOFA is just a quick assessment on whether a patient is septic or not. So blood pressure of less than 100, respiratory rate over 21, and altered mental status, or GCS, of less than 15. And again, this in combination with SIRS is good indicators that your patient, in the presence of a known or presumed infection, that your patient could be septic. But now there's one other vital sign that isn't in any of these criterias that us as pre-hospital users need to be paying attention to. Okay, so that last vital sign, or that last step in our criteria, SIRS criteria, or excuse me, sepsis criteria, is end tidal. There's a lot of good data out there talking about how well end tidal does at diagnosing sepsis in patients, right? We're not fully diagnosing a patient with sepsis in the field, but sepsis is a very good tool to give us a good indication whether a patient is septic or not. I had a patient that was an older gentleman, got called out to his house as a sick person, showed up, he was awake, alert, GCS 15, no issues there. Family said he's been sick recently, had like the flu, COVID, something like that. He just didn't look like he felt very well. He got on our cot. We started checking his vital signs. All of his vitals looked great, except for one thing was a little bit off, and it was his heart rate. His heart rate was pretty high. It was about 140 something. No cardiac history, nothing like that. Got him out to the med unit, again, started checking everything. Everything was fine. And so I thought, I wonder if this guy is septic. Respiratory rate was fine, SpO2 was fine, all that. So I threw him on some end tidal. Threw him on a nasal cannula to see what his end tidal was. And throughout my transport, which was about 12, 15 minutes, his end tidal never got above 19. It hovered around 17 to 19. Got him to the hospital. I did the whole sepsis, code sepsis, started some IVs on him, gave him some fluids. We got him there, dropped him off. I checked back in later and found out that he had a lactate of 15. If I remember correctly, it was like 15 or 16. It was way up there. He was a very, very sick individual. And so that end tidal correlates very well with sepsis. And a lot of times, if it's less than 25, correlates with severe sepsis. So always, if you have a patient you suspect is septic, throw them on that end tidal. Just because their SpO2 is 98 or 100%, throw them on that end tidal. We're not using the cannula for oxygen administration. We're using it for that end tidal reading, and see what their end tidal is. And then lastly, management of these patients. What can we do for them? I know that a lot of departments, if your department or agency may already do this, give antibiotics pre-hospitally. It's a very good tool. The data is showing that we could have a dramatic impact, especially in a very, very sick septic patient, hypotensive septic patient. That early administration of antibiotics has shown to be very successful, very beneficial. And then fluids, obviously, that's kind of been the mainstay of these septic patient treatments. And then pressors. Don't forget about your pressors. If you have a hypotensive or suspected septic patient, and their pressure is crummy, get those pressors on board. Whatever your department or agency uses, get that pressor on board along with the fluids. Get them up. That's going to buy them some time again in the hospital to get that figured out and get that infection under control. Anyway, hope that helps. We'll see you guys in the next one.